This is Dr. Ben Weitz with the Rational Wellness Podcast, bringing you the cutting-edge information on health and nutrition from the latest scientific research and by interviewing the top experts in the field. Please subscribe to the Rational Wellness Podcast on iTunes and YouTube, and sign up for my free ebook on my website by going to drweitz.com. Let's get started on your road to better health. Hello, Rational Wellness Podcasters. Thank you so much for joining me again today. For those of you who enjoy listening to our Rational Wellness Podcast, please go to Apple Podcasts or wherever you get your podcasts and give us a review and a rating. We would really appreciate that. That'll help move us up in the rankings there, and more people can find out about the Rational Wellness Podcast. Also, go to my YouTube page and you can find a video version. And if you go to my website, drweitz.com, you can find detailed show notes and a complete transcript. Our topic for today is mitochondrial testing with Dr. Sri Ganeshan. A mitochondria is plural, is an organelle found in every human cell except for red blood cells. In fact, most cells have numerous mitochondria. ATP is the main source of energy, chemical energy used by cells to fuel their functions. And this ATP is generated by the mitochondria, which is why the mitochondria are often referred to as the energy powerhouse of the cell. Mitochondria have many other roles besides energy production, including heat production, the storage of calcium ions, cell signaling through reactive oxygen species, programmed cell death, regulation of cellular metabolism, and steroid synthesis. There are primary genetic mitochondrial diseases, which are relatively rare, such as Barth syndrome, aminoaciduria, iron overload, Kearns-Sayre syndrome, and mitochondrial encephalomyopathy. But much more common is mitochondrial dysfunction, which is a characteristic of aging and a component of nearly every chronic disease, including neurodegenerative diseases like Alzheimer's and Parkinsons, congestive heart failure, autoimmune diseases such as MS and lupus, neurobehavioral diseases, including autism, schizophrenia, bipolar disorder, chronic fatigue, fibromyalgia, and even cancer have a mitochondrial component. Mitochondria can become dysfunctional when we lack the necessary mitochondrial support nutrients, when the energy created by the mitochondria is less than the free radicals they produce, or when mitochondria are damaged by environmental toxins, medications, or the dirty electromagnetic fields that surround us in modern life. Environmental estrogens like bisphenol A and pesticides, glyphosate from Roundup, and heavy metals like lead and mercury all damage our mitochondria. Also, common medications like acetaminophen or Tylenol, as well as most non-steroidal anti-inflammatory pain medications, many psychotropic medications like Prozac, cholesterol-lowering statin drugs, and even metformin are all known to be toxic to our mitochondria. Dr. Sri Ganeshan is the Chief Medical Officer of Religen DX, a company focused on mitochondrial disease research, including the development of the swab test, a non-invasive way to analyze mitochondrial dysfunction. Dr. Ganeshan, thank you so much for joining me today.
Thank you, Ben. Thank you for inviting me. Thanks a lot. I think you summarized very well.
So tell us about your personal journey and how you came to become involved with research on mitochondria.
Yeah, I accidentally, I was in a vacation and I happened to be, the same hotel happened to have a autism conference. That's how I found my way into the autism world. And then by learning about autism, I also found out that a significant percentage of patients with autism have mitochondrial dysfunction, up to 80%. Now, autism, as you know, thousands of disease, hundreds of disease put into one diagnosis, and there may be different phenotypes. So some may be because of the folate issue, some may be because of mitochondrial issues, the other may be because of a gut issue. So I think one treatment doesn't fit all. So we found this scientist and we collaborated with him and came out with this test, which he has been kind of working on it for a long time. So that's how the Mito swab came into picture. It's a buccal swab test, very easy to do, non-invasive. It mimics the muscle biopsy, and it has been compared to the muscle biopsy with an 84% correlation, which is published in a peer-reviewed journal.
So the muscle biopsy is, prior to this test, has been the only real test of a mitochondrial status, right? Where you actually biopsy part of the muscle?
Yes, the muscle biopsy is being considered the gold standard. But for primary mitochondrial disease, now the genetics is taking over from the muscle biopsy because of the easy nature of doing genetics. But overall, muscle biopsy is considered the gold standard.
Right. But of course, the average patient who maybe is coming to see a functional medicine practitioner for some condition that's related to mitochondrial dysfunction, they're not going to be good candidates to get a muscle biopsy.
Absolutely. And we don't have the kind of expertise or the knowledge how to even manage. There are only a few people in the country who can read a muscle biopsy today. It's going out of favor. So we need new tools, and hopefully this is a good start. So
I gave a little intro about the mitochondrion, but maybe you can explain a little more about exactly what a mitochondrion is and why is it so important for health?
Yeah. Ben, you did a fantastic job. There's only very, very less I can add to that. So the mitochondria, as Ben mentioned, is the primary energy source, the energy currency produces in the cell. So he went in depth at telling that only the red blood cells don't have mitochondria. And why is that? It's because red cells carry oxygen. And so mitochondria uses oxygen to produce energy. So if that's the case, red blood cells can't carry oxygen. So that's God's gift to humanity, I believe. But on a serious note, mitochondria, the function from 2 to 60 years is kind of very standard. And then after 60, it starts declining. That's why when it starts declining, you see a series of disease coming into our life, like cardiovascular disease, neurodegenerative disease. These are diseases of the old age. So we see them coming back. So for a healthy aging, you want your mitochondria optimal. You want it optimized. So that's very important, and that's the doctors are now realizing that. The practitioners are treating that very well, and there are a lot of tools to do that. Exercise, for example, is one of them. Is shown consistently that to improve mitochondrial function.
By the way, are you familiar with particular forms of exercise and which is the most effective form of exercise to improve mitochondria?
Yeah, there are different studies to show that. What they call is a regular exercise, which is consistent and which is applicable to all human, everybody, is what is making a difference.
So, for example, aerobic or cardiovascular exercise versus resistance or strength training, is one of those better, or is short bursts of aerobic exercise versus lower intensity, longer duration?
Low intensity has shown benefit. Resistance exercise have definitely shown exercise. These are studies I'm quoting. I mean, they've shown that they're better. More intense exercise, I think we can avoid. It's not applicable to common, but a sports person, that's very much applicable. But for a common man, I think consistent resistance training is definitely important for muscle mitochondrial function. So it's very important. Yeah.
Okay. And I've heard people discuss strategies for improving mitochondrial density.
Yes, yes. To go back to the basics, the food we eat enters into the mitochondria through complex 1, and there are five complexes. Enters into the mitochondria through complex 1 and 2 as electrons. Now they are transported through the complex 3 into complex 4, where the oxygen we inhale is converted into water. So the mitochondria plays two important roles. One is breaking down the food we eat. The other one is converting the oxygen into water, the oxygen we inhale. 95% of the oxygen we inhale is converted into water. 5% escapes and form oxygen-free radicals, and 5% is okay. They are known to act as signaling molecules, like you pointed out. And beyond that 5%, maybe if it's 20% of oxygen escapes and form oxygen-free radicals, that's when your body gets affected. They damage the proteins, DNA in your cells, so that becomes a problem, and that manifests.
So let me just stop you for a second. So too much free oxygen is a free radical, and that can cause damage to the cells. A certain amount is important for signaling, but too much, like you said, for example, 5% might be good as a signaling agent, but 20% would be too much and cause cell damage.
Absolutely right. That's right. So we can measure that through the MitoSwab. We can approximately tell you that what's happening there. So MitoSwab is very specific, and it just helps you understand better. But then the complex 5 is where the energy is produced, ATP is produced. Because of this energy production, electrons escaping out, hydrogen molecules are escaping into the creating a electrochemical gradient in the outer membrane. What happens is the ATP is produced because of that. Because if there's a high electrochemical gradient outside, it wants to come inside. It's like putting more pressure, water, and it's like a dam. You save water, it wants to come out, and you open up. The turbine moves and it produces electricity. It's the same mechanism. ATP is produced from ADP. The ATP is very important for many functions. You pointed out quite a few of them, and that's what the mitochondria does. So if there's a problem in the first 4 complexes, then there is definitely a problem in the energy fluctuations. There is a leakage, and we don't want to go into complexities, but definitely affects the mitochondria, hence the body and clinical symptoms manifest.
Okay, so these different complexes you're talking about, there's this complicated chain of processes that leads to ATP energy production, right? And these are different pathways in that process. Is by when you talk about complex 1, 2, 3, 4, 5.
Absolutely, and certain diseases are associated with certain complexes. For example, the complex 1 is associated with many diseases, including diabetes, one of them, neurodegenerative disease, and etc., neurodevelopmental disease. But the complex 4 is affected with neuromuscular disease, seizures, and things like that. So there's a lot of evidence. There's a growing body of evidence as well. The complex 3, for example, is very, very important in T cell regulatory function, endothelial function. So they play a very critical role. Your defense against infection, your defense against inflammation, and things like that. So mitochondria is not only energy producers, but also many other functions, very important, critical to the human survival.
So you mentioned complex 1 is related to the cause of diabetes. So diabetes is also considered a disease where mitochondrial dysfunction is important?
Absolutely, and there's a lot of ongoing research and published research as well. And if you look at drugs, metformin acts on the mitochondria. It actually boils down to that critical level at that point. So, but definitely, yes, diabetes is considered a mitochondrial part of a mitochondrial dysfunction.
So what does that say practically for those of us who are managing patients with diabetes? And by the way, I found in some of the articles that metformin can actually be a negative for mitochondria.
Yes, so metformin definitely works through the mitochondrial pathway. So that's why when you give every drug, you have to check where the effect is, like, for example, statins. reduce CoQ10, that is ubiquinol. And that's very important for the electron transport from complex 1 and 2 to 4. So that they are electron carriers. So that's very important. Now, statins decrease CoQ10. In the United States, it's not every practitioner prescribes CoQ10 along with statins. But it's good when your body is good, like say up to 50, 60 years, then your internal production of CoQ10 comes down, and then you give statins over that. Then the long-term effects of that is kind of, we don't know, but definitely we can predict something that if your CoQ10 is low, your mitochondria is not functioning. But that's why in countries like Japan, it's mandatory to give CoQ10 along with statins. So if you put a statin prescription in Japan, you have to prescribe CoQ10 as well.
Yeah, I interviewed Dr. Barry Tan recently, and he was talking about the importance of having patients who take statins also take tocotrienols, which also helps to protect them CoQ10.
Absolutely. So there are other compounds. Ubiquinol is the most important one, and there are other compounds as well. Ibidinol is one of them. Definitely, it's easily available, and there are a lot of developments which are happened in that space.
This episode of the Rational Wellness Podcast is brought to you by Swab, which is the only non-invasive test for the mitochondria. We know that the mitochondria are the energy powerhouses of our cells, and that a breakdown of our mitochondria can play a role in many chronic health conditions, including chronic fatigue, congestive heart failure, and even cancer. But until now, the only way to measure mitochondria has been to do a painful, invasive biopsy of our muscles. But now, by swabbing your cheek, the MitoSwab test can help us to analyze mitochondrial function by measuring the activity of the electron transport chain. And it has an 84% correlation with muscle biopsy. If you are a doctor, go to mitoswab.com to sign up and order a test kit, or call 484-534-9311. If you are a patient and you have interest, you need to see a functional medicine practitioner like myself who could order the MitoSwab as part of the testing protocols for an analysis of your overall health to help set you up on a program to improve your health and prevent chronic diseases. So coming back to diabetes, what can we do if we're managing patients with diabetes if we now know that part of the diabetes process is involves mitochondrial dysfunction?
Excellent question. You want to think about when you have a patient with diabetes, your multi-system is affected. It's not just one system is being affected. Your multi-system is affected. And you want to, we are early on the cycle. I think there are pioneers in this field who are looking at mitochondrial function in diabetes. For this to come to mainstream, it's going to take another 10, 15 years because we don't have the tools to do that, optimized tools, and it's not part of any guidelines. So right now, treat them as you treat, but also look at the mitochondrial function. By improving the mitochondrial function, you may be able to optimize the drugs, reduce the number of drugs, get the patient better, or reduce the side effects of diabetes, like vascular dysfunction, improve cardiovascular dysfunction, or things like that. You may be long term. It's diabetes, is a short term disease. Its effect is long term. It's years and years. So you want to minimize by improving the mitochondrial dysfunction. Your requirement of medications may decrease. It's not shown in any studies. I'm sure somebody is working on that, but definitely that's something, the pathway to go to improve mitochondrial function. So you optimize the patient overall.
Right. So you're saying that when we have a patient with diabetes, in addition to looking at a lot of the typical things we might look at, like blood sugar and hemoglobin A1C and advanced lipid analysis and inflammatory markers, we might look at mitochondrial function by, say, giving the patient the MitoSwab test as part of better managing their condition.
Absolutely, this could be one of the tools available, easy tool to see what the mitochondrial, in functional medicine, you want to optimize the patient, you want to reduce the patient's disease burden, you want to be preventive. I think when you talk of preventive medicine, mitochondrial function becomes critical. Like if you take neurodegenerative disease, now we are expecting to have 14.2 million people with Parkinson's in 2040. And 14 million people with Alzheimer's. That's a huge burden on the society. Now, if you look at Parkinson's disease, that's clearly linked to mitochondrial function. There are a lot of evidence. You can search the publicly peer-reviewed evidence. There's a lot of evidence on Parkinson's and mitochondria. In fact, some of the mitochondrial genes have been implicated in Parkinson's disease. Now, by identifying earlier on, this may be too early to the cycle, but if you identify a patient vulnerable, you may be identifying a vulnerable patient. By taking action and correctly following up, for example, at least this stage, with somebody with a family history of neurodegenerative disease or Parkinson's disease, you may want to identify if there's a mitochondrial dysfunction. And so you want to kind of take at least that one equation out of your cycle. There may be other factors, environmental and unknown factors, but at least you're taking by improving mitochondrial function, you're able to clean up your body better. You're able to chelate chemicals better. You're able to remove unwanted substance better. So I think the mitochondrial function plays a critical role in modifying that. I think the future research, if you see the number of publications in mitochondria, they have tremendously improved. There's a significant improvement of publications on neurodegenerative disease and mitochondrial function. So I think the next 10, 15 years, you will see a significant improvement in mitochondrial diagnostics and mitochondrial management of mitochondrial.
Interesting. Is there data to show that if we let's say we work up a patient for Parkinson's from a functional medicine approach, and we're trying to look at various markers of disease progression, and we add mitochondrial analysis, say through the mito swab. If we can improve that, does that correlate with better outcomes for Parkinson's?
Yeah, so these are long-term studies. We don't have data at this point of time. We have some animal data showing that improving mitochondrial function may improve our outcomes, and also some human data as well. But we need more work on that. We need to understand more nuances there. And I'm pretty sure that 10 years ago, 15 years ago, somebody talked about the microbiome. You were an alien. So today, it's going to mitochondria is kind of the next generation thing. I think you can definitely decrease the disease burden, improve outcomes. We don't have evidence because these studies will take 10, 20 years to do that. And so we have to look at large databases. And with the tools like artificial intelligence and data analysis, I'm sure we can come out with some solid data.
But do we have data now showing that patients with more advanced Parkinson's, Alzheimer's tend to have worse scores on, say, the mito swab test?
We are collecting data. We don't have the data, published data as of today, but definitely that's a goal that we are definitely collecting data on that retrospectively, talking to physicians consistently, doing that. But I'm pretty sure that we will be available in maybe 2 years' time.
Interesting. Have you talked to Dr. Dale Branson, who has his program for prevention and reversal of Alzheimer's?
Very briefly, yes. Very briefly.
I would think he'd probably be interested in this as another marker for being able to gauge progress in making some progress against some patients with some of these very serious neurological diseases.
Yeah, he had expressed interest, but the contracting and the process takes a long time for clinical studies.
Okay, so you mentioned cardiovascular disease. So what part does mitochondria play in cardiovascular health and disease?
Many. I mean, if you look at all the heart failure patients, mitochondria are significant. So muscle function. So let's go to the basics again. you mentioned that different parts of the cells have different number of mitochondria per cell. Like if you look at the skin may have 10 mitochondria per cell. There's only one nucleus, but they're per cell. But if you look at the muscle, which has more energy needs, you need thousands of mitochondria per cell. And if you look at the brain cells, it's a similar, it's more energy needs. So based on the energy needs, the number of mitochondria per cell also differs. Heart cells naturally need more energy and they have more mitochondria. So one of the hallmarks of heart failure, and if you look at, there's one actually published paper every month or 2 or 3 published papers on heart failure and mitochondrial function. So definitely mitochondrial function plays a critical role in heart failure. So one of the things we are trying to do is validate this test with the heart muscles as well, and also look at whether patients by treating these patients by producing the energy production, making the heart muscle function better, pump better, produce more energy, are we able to have better outcomes? Are we able to delay the process of heart failure? So we are thinking in that direction. There's also a recent paper looking at coronary vascular disease and mitochondrial function, especially the electron transport chain. It was published within the last 2 months. A very nice paper looking at electron transport chain function and cardiovascular disease. I'm talking of coronary vascular disease. So by measuring it, are you predicting that, hey, a low mitochondrial function patients may be vulnerable to cardiovascular disease?
So how does the mitochondria play a role in this process that we normally think of as involving an inflammatory oxidized LDL particles creating plaque in the arteries?
Fantastic question. So the LDL deposits the cholesterol in the heart vessel walls. Then the HDL picks up those cholesterol and takes it to the liver for degradation. And that process involves a process called reverse cholesterol transport. And that process involves ATP. ATP plays a very significant role there. And that's an energy dependent process. So mitochondria definitely plays a role there in cholesterol transport and also in the health of those patients.
Interesting. So what you're saying is some of the nutritional things we do to support the mitochondria, say like nutritional supplements like coenzyme Q10, L-carnitine, D-ribose, alpha-lipoic acid, things like that tend to support the health of the mitochondria. It's now part of a functional medicine protocol to use those for patients with congestive heart failure, but you're saying that those would be beneficial for patients with atherosclerosis as well.
Yeah, so the atherosclerosis is a chronic disease, I would say. It goes for a long period of time, and you only don't know when it develops and when it kind of ends, right? So you don't know when it starts. So there are very less tools to identify that right now, and there are some tools now, but definitely looking at mitochondrial function plays a critical role in that cycle. That's what that paper also kind of suggested. Definitely, all these supplements you mentioned, they have critical roles. For example, carnitine is used to helps in the transport of long chain fatty acids. That is fatty acids with more than 14 carbon atoms into the mitochondria. Now the small chain fatty acids, they enter the mitochondria without any help. But carnitine is used to transport large chain fatty acids. CoQ10 is an antioxidant and helps in the transport electrons. It's an electron transporter. It helps in the transport.
By the way, what are some examples of short chain fatty acids and what are some examples of long chain fatty acids?
Yeah. The short chain fatty acids, you're talking of butyric acid, propionic acid, and things like that, which is less than 6 carbon.
And those are typically produced by gut bacteria.
Absolutely right. I mean, there's a lot of evidence on butyric acid, especially very important for the colon function. And butyric acid also improves mitochondrial function. Especially, there's papers in the autism kids showing that butyric acid helps the complex 4 function and overall modifying the mitochondria. So very important.
And we could probably add medium chain triglycerides, such as from coconut oil, as well, right?
Yes, they have a different role to play, but short chain fatty, especially the butyric acid, is very critical for health and everything, and also the mitochondrial function. The long chain fatty is a palmitic acid and things like that. Normally available in your food, so they don't.
So these are found in things like saturated fats and polyunsaturated fats, like omega 6s and 3s.
Yes. So carnitine is needed. So if you do a carnitine profile and if carnitine is not carnitine is low, that means your long chain fatty acid is not entering the mitochondria. Now, if you take fat, they produce more energy per molecule as compared to carbohydrates. So that's also very critical, technically speaking. So
9 calories per gram for a fat versus 4 calories per gram for a carbohydrate, and that's a measure of energy.
Good. Yeah. So that's something like that. So so certain diseases, for example, you're talking keto diet and that sort of thing. So you want to be very careful as well. You don't want to give a supplement just for the sake of giving it. For example, if you're looking into carnitine, you want to give carnitine. You want to know if this patient really needs carnitine. You don't want to throw in carnitine just like that. You want to know what supplement you don't want to over supplement. You don't want to under supplement. You want optimal supplementation. And you want to know only when what cofactors are needed. So, for example, the cofactors for complex 1 and 2 are kind of different. And people have been using NADH. NADH is good for complex 1. So it's supplement riboflavin for complex 2. So the supplement cofactors differ. And so you want to be careful on what supplement you give, what is the amount you give, things like that.
Okay.
To add to that point, we don't have a FDA-approved drug for mitochondrial dysfunction. There are several companies investigating, and I'm hoping that in the next few years there'll be several drugs focusing on mitochondrial function into the market. So that will really give a boost to this whole world and education, physician education. In addition to people like you who are trying to get the word out, there is also going to be these companies putting their resources behind to develop their education tools for physicians to understand.
But there's certainly studies, say, for example, with congestive heart failure, that CoQ10, L-carnitine, and D-ribose have all been shown to be beneficial.
Absolutely. Absolutely. Absolutely.
This is something that's been pointed out a lot of times by Dr. Steven Sinatra, who's written a lot about this.
No, absolutely. Definitely, the nutritional supplements which help mitochondria have shown benefit in double-blind placebo-controlled studies. CoQ10 is one of them which is used. For example, just imagine this. This is just not, I don't have the evidence to talk, but look at if somebody is having statins for 30 years or 25 years, and consistently, one point of time, the body is able to keep up producing CoQ10. At one point of time, you become a little older and the body's ability to produce CoQ10 decreases. What happens in that case scenario? There's no studies to prove that, but it's just we need to be proactive in thinking in that direction. So we are able to find, and so research studies have to be designed in that on that tool. Yeah.
Interesting. So in addition to your Mitel swab test, since we've been talking about cardiovascular disease, you also have been instrumental in bringing to the market a cholesterol efflux capacity test. Can you tell us what that is? And
yeah, fantastic. So this is a very new test we launched last week. The cholesterol efflux is the first step in the reverse cholesterol transport. As I mentioned earlier, the LDL deposits cholesterol in the blood vessels. HDL picks it up, brings it to the liver for degradation. Now,
By the way, for people who are not familiar, for laypersons who are listening to this, LDL is the so-called bad cholesterol because it tends to be involved in the process of leading to clogging of the arteries, whereas HDL is the so-called good cholesterol because it tends to take some of that cholesterol from the arteries and remove it from the body.
Absolutely. I think, thank you for pointing this out. So this is a very good way of explaining. So LDL is considered the bad cholesterol and HDL is considered the good cholesterol. But we have traditionally reduced LDL by taking statins. Statins are very successful in reducing LDL, but they don't have an effect on the HDL. There are several drugs which have been tried.
They also don't do anything about increasing LDL particle size.
Yeah, so when you go back to the HDL, HDL is very important. You want HDL, that's the good cholesterol in a particular, within a particular range. You don't want to have it too low. You don't want it too high. That means more than 100. I mean, very few people you can find that at that kind of level. What do you want to do?
Usually if the HDL is too high, that's because it's not functional, right?
Yes. Too high is also not functional. Too low is also not getting used. So you want it somewhere like in a good range, somewhere above 40, somewhere less than 90, 80.
Now, prior to this test, basically the best measure we have is if the HDL particles are larger, then that's an indication that they're more likely to be functional.
Yes, you're right. And HDL particles has also been examined in double-blind placebo-controlled studies. The cholesterol reflux is studied and published more than 4,800 times in peer-reviewed journals, including 14 papers in the New England Journal of Medicine. Now, that's very well described, but the converting that into a commercially available test has been very difficult. The reason being is a cell culture assay. It's a very cumbersome process. So we've been able to do that. It's a proprietary test. We've been able to do that. Our lab is one of the best, our partner lab, which we kind of collaborate, is one of the best labs in the vascular medicine. They mostly work with research groups and pharmaceutical companies. We thought there was a critical need for this test for patients, and so we are trying to get it to patients. So coming back to the HDL transport, in the reverse cholesterol transport, the first step is getting the cholesterol outside the blood vessel walls, the macrophages there. So that process is called efflux, and that process is also energy dependent. There's a mitochondrial component there, but also if that process is not working properly, there's a problem. You may have a good HDL level. You may have a good HDL level. You may not have a good cholesterol efflux. So that means your HDL level is not going to matter. So there are studies showing that independent of the HDL, LDL, and cholesterol particle size, cholesterol efflux is an independent risk factor for patients who do not have heart disease, diagnosed heart disease, and people who have diagnosed heart disease or coronary vascular disease. So it's considered an independent risk factor. So if you look at the drugs which were developed to increase HDL, they all increase HDL. They did that function, but that increase in HDL is not translated into improved cardiovascular outcomes. That's what many of these drugs fail. Now, one of the reasons for that is that they didn't translate into improved cholesterol efflux function. They didn't account for that. So that becomes very important. And this I hope this marker is going to help a lot of people. As also recently, this cholesterol efflux has been compared to coronary CT. Now, there's coronary CT is becoming very popular because of its cost effective and it's producing something called.
You're talking about the coronary calcium scan, right?
Yes, absolutely. So that's becoming popular, but there was a correlation study recently published within the last 5 days, looking at whether it's compared to that. This is the only one which was compared. Cholesterol efflux, the only one which was compared to coronary calcium score. So I think combining, people have to come up with scoring systems and things like that. And no drug currently available improves cholesterol efflux. The only thing which will improve is exercise, which is showed in a study, and also behavioral modification. So it's very important to understand your risk score. So somebody with come to you, for example, tomorrow to understand, hey, I have a family history of heart attacks, and what do I do? So one of the things you may want to consider for this particular patient is the cholesterol reflex test. So I'm hoping that in the next few years, maybe 3 to 5 years, this becomes part of the guidelines recommendation by the American Heart Association. That's the expectation, hopefully. That's something.
So other than exercise, are there any nutraceuticals or dietary changes that can be beneficial for improving cholesterol reflux?
Good question. We have seen exercise in a very robust study shown to improve cholesterol reflux. That's the only one which is shown. Nutritionally, there are studies which are shown to improve, but I think we need more studies. There are definitely studies by improving mitochondrial function. They're shown to improve cholesterol reflux, but definitely we need more robust studies, well-designed studies.
What about niacin? Can that improve cholesterol reflux?
Niacin has been studied, but it's not shown to improve cholesterol reflux consistently.
So right now we don't have anything.
No, nothing. Okay. One of the things we may consider, there are studies on CoQ10 and other things, that may be something to consider, but we still need that, much more well-defined double-blind.
I see. Interesting. Well, the studies that were done with CoQ10, do you know any idea what the dosages used were?
I don't know the top of my head, but the CoQ10 has a number of factors. CoQ10, the dosage matters, the formulation matters. It's very sensitive to light. It gets oxidized. So there are a lot of factors in CoQ10. And I've been, even though we don't have the evidence to support, selecting good CoQ10 is also an art, I say. We need standardized protocols for good CoQ10.
What do you mean a good CoQ10?
So, how they are transported, how they're protected against light and things like that. What is the formulation? Because there is also, attempt to make CoQ10 a drug. So, but I think the supplement companies need to come together and find a lot of absorption studies and things like that.
So as far as I know, all I've heard is that we have ubiquinone and ubiquinol. And then there's one company that has a product called Mitochondrial. What are you referring to in terms of formulation?
For example, Mitochondrial, they've done a fantastic job to do a lot of research studies. They're publishable, so I would give them the benefit. But there are also other CoQ10s which work. So there are two main manufacturers of CoQ10. One of them is a company called Ganeshan. There's another one in New York. The New York one is a bacterial fermentation process. Ganeshan is a different process. So, the finer details we need to understand, and also who is repacking them and things like that. Is the process much more cumbersome? So I'm not telling you anything bad or anything, but definitely some CoQ10s definitely have not seen any effect. But some, when you change the brand, they get affected. So we need kind of to work on that. For example, the CoQ10 available in Costco works brilliantly.
Say that again?
The CoQ10 available in Costco works very well. Metagenics has a good brand, and there are several companies which have good brands. Qunol is good.
Okay. And we can monitor this by using the Mitel swab test for its effect, right? Oh no, we're talking about the cholesterol reflux test. So we can do
the cholesterol reflux test is a good test. Cholesterol reflux test is a good test.
It's a serum blood test?
Yes, it's a serum blood test. It can be used to kind of identify the issue and also monitor the effect of the issue for long term. So
practitioners who want to utilize these tests, they can do the test through your lab. Is that right?
Yes. So currently we are the only lab which are offering commercially these two tests. Cholesterol reflux is offered by some research labs at this point of time, but we think our methodology is kind of superior to the existing methodologies. So we think we offer a very unique methodology and very validated methodology.
So practitioners could call your company and get what, like a test kit and then
yes, absolutely. Absolutely. So we launched it last week.
Last week. Well, no wonder. I talked to a cardiologist who said he wasn't familiar with it. So.
Yeah. So we are getting a lot of calls. We didn't even advertise, but they're getting a lot of calls because we believe that this test is going to be used uniformly by everybody.
What is the approximate cost?
We work with insurance mostly. The out-of-pocket maximum should be around $300.
Okay. Are you finding that some insurances are picking it up?
Possibly, yes. For cholesterol reflux, we are just waiting approval. But for MitoSwab, Medicare pays for MitoSwab.
Interesting. How about commercial insurance?
We are not in network, but some of them pay. Some states, Medicaid also pays for MitoSwab. So we're waiting to become an in-network provider for those insurance. But yeah, our goal is to get it approved by insurance.
Great. So how do practitioners get a hold of your lab? Where would they go to? Should they go to the website?
Yes, we have a website, www.religiondx.com. Also, we have another website.
What was that again? www.
Religion, RELIGEN, DX.com.
Okay.
They can also visit Mitel. So we have a separate website for Mitel since we started with that. So they can go there and give an email.
So they can go to Mitel swab, MITOSWAB.com.
Absolutely right. And they can call us. They can email us.
What's your phone number?
Our phone number is 484-534-9311.
Okay. And what's the approximate cost? What's the cost of the Mitel swab if the insurance doesn't cover it?
So the maximum out of pocket for insurance is $400 for a patient.
$400. Okay.
That is the maximum out of pocket call if the insurance doesn't cover.
Okay. So they supply their insurance. You try to bill the insurance, and if the insurance doesn't cover it, then the max would be $400.
Yeah. So some of the patients don't want to deal with the insurance, and so for them, the maximum out of pocket would be $400.
Is there a discount if they just pay cash up front?
No.
Okay.
The upfront or later is the same thing. So no.
Okay. Sounds good. So I appreciate the information you brought us, Dr. Ganeshan. This is really interesting. Another tool in our arsenal to help manage our chronic disease patients. Now we finally have a non-invasive way to monitor their mitochondrial function. So I think this is very exciting.
Thank you. No, that's a very important tool. I think last 10, 15 years, we heard about microbiome. We learned a lot, and we are still learning. And the next 10 years, we continue to learn about microbiome, and we'll start learning about mitochondria. The good thing is that the mitochondrial medicine has a lot of activity in the recent years. There are companies which are developing drugs. There are companies which are developing diagnostics like us. We need a good, healthy competition, and we need to get the best for the patient and good tools for the practitioners to identify and take effective action. So I think it's very exciting time for the mitochondrial medicine world, and the experts are coming together. There is in fact a conference I'm thinking of attending. The George Washington University of Integrative Medicine is organizing in Dallas in October. So things like that. So I think you'll hear a lot about mitochondrial medicine in the next couple of years.
So actually, we're announcing right here on this podcast that the next decade is the decade of the mitochondria.
Yeah, thanks to people like you. Yeah, so hopefully that is because I think we can solve a lot of problems, unidentified problems. We don't know why why there's an increase in cardiovascular disease. We don't know why there's an increase in neurodegenerative disease. We may have an answer. Part of the answer may be lying here, but we know. I think we need more research, and we need more evidence to take action. So I think that we are going in that direction.
Awesome. Thank you, Dr. Ganeshan.
Thank you, Dr. Weitz. Thanks a lot. I appreciate your time and having us in the call.